Well, good morning. I am Li Mei Chen. I'm the division director at UCSF, and I am trying to get started our 12th annual GYN Cancer Symposium. I appreciate you all attending this morning and your patience bearing with us as we have run into a few technical difficulties. We are having trouble with getting the audio working for the program, but it does seem like we can share some slides. And it sounds like you guys can hear us. So I think that in the interest of time and your attention and the fact that our speakers are here and ready to present, we will go ahead and get started. As I mentioned, this is our 12th annual GYN Cancer Symposium. September is GYN Cancer Awareness Month. And for many years, we've tried to put together a assembly of science as well as survivorship challenges and voices of the patients. And so this is our 12th annual symposium. Today we have, now I have to figure out how to move my screen. And that doesn't work. Okay, today we have highlights of our J.J. Zhang Memorial Lecture, which is going to be presented by Dr. Gottfried Konecny, visiting us from UCLA, but actually visiting us from Korea, zooming in. And then we'll have a couple of panel discussions that are led by some of our patient advocates. And we hope that we can share knowledge and science and be able to share ideas and talk to you a little bit more about new developments in GYN oncology. Okay. No. Okay. I also wanted to acknowledge our friend circle, and some of you may have joined the friend circle event yesterday evening. The friend circle is a patient-led circle of friends who bring together discussion for GYN cancer. They are our patients, they are our friends, they are our caregivers, and we really want to have a network that you can all participate in as well. As you can see, this is their email address, and they meet pretty regularly on Zoom, so it's not hard to get to. Their next gathering is on October the 19th. They also are our partners in putting together this symposium. So I wanted to thank Sarah and Rachel and Stacy and Nina and many of the others who have joined in to help with putting this symposium together for us today. Our first speaker is Dr. Gottfried Konecny, and I wanted to introduce first the concept of our J.J. Zhang lectureship. Now, don't see my screen.
Do you want me to share now, Li Mei?
I was actually trying to show the slide of Ms. Zhang and really thank J.J. Zhang and her family. Ms. Zhang was a patient of Dr. Chapman's here in our cancer center, and her family, thank you, really wanted to appreciate the courage and sacrifice that she made for the family, and also to acknowledge the care that she received here. This is her portrait. Thank you, Kevin, for getting that up for me. And in honor of her, we present our first speaker to our symposium this morning. Dr. Gottfried Konecny is a professor at UCLA, and he is a trained GYN oncologist practicing in medical oncology. He is internationally recognized for his bench science and was specifically requested by our friend circle to come speak with us today. He's going to be speaking on the novel development of antibody drug conjugates from bench to bedside. And Dr. Konecny, I appreciate you joining us today from Korea at 1 in the morning. Please share your slides, and we'll continue to work on this AD issue as we go along. We will be taking a Q&A at the end, so please put your questions into the chat, and we'll try to get to as many of them as we can. Thanks.
Thank you, Li Mei Chen. I'm going to share my screen now.
Try your video again one more time, just for thanks.
Yes. Let me double check. It says you cannot start your video because the host has stopped it. It still says that. So I think, Kevin, thanks very much. I think the problem is that we can't show a video of ourselves, which probably is not that detrimental right now because it's late at night for me. But the reason is here I'm in Korea because I'm excited to be here because we've been working on a novel ADC that was born out of UC Lab, University of California, and this is now going into clinical trials in Korea. And I visited some hospitals and we had a symposium here. So it's exciting to see that at a different part of the world, patients are struggling with the same problems that we have, and just having this global connection that we're dealing with issues of human nature and human society is just extremely rewarding, not to mention the hospitality here. Um, so Lee May and Kevin, I hope you can see the slides. Is that correct?
Yes, we can see the slides.
Perfect.
Right. And I did put in a picture because you can't see me, so it's not going to be following you, but this is what I look like. But I wanted to talk about novel antibody drug conjugates. And this is an exciting topic because we have so much to talk about now. And I've been at a meeting here. I was just at a meeting in Europe, and we have afternoons filled with talks about novel drugs that are moving forward for women diagnosed with either ovarian, uterine, or cervical cancer. And this hasn't been the case since a very long time, that we have so much to talk about, and that there is so much in development. And this is a cartoon showing you that it's confusing for us who deal with this professionally, and more so probably for patients, in that we have 14 approved antibody drug conjugates. There are actually 190 now actively being explored in clinical trials. And unfortunately, 150 of these have already been discontinued because they didn't accomplish what we were hoping they would be doing. So I think understanding a little bit of the basics will help you guide and navigate the clinical trial landscape that is rapidly evolving in Southern California. Now, antibody drug conjugates are a new type of medicines which deliver chemotherapy with greater precision to malignant cells, and they utilize something that we're linking chemotherapy to a monoclonal antibody that binds to a receptor on the surface of cells. So you can see a cartoon of a cell, and there are proteins sticking out. These are various functions. And you can see on the right side, the red and yellow, these are monoclonal antibodies binding to these surface receptors on the surface of a cell. And in the next cartoon, you can see when this monoclonal antibody is linked to a chemotherapy drug, we call this payload. The hopes are that this drug would be delivered with greater precision to malignant cells. It's important that we pick targets that are not expressed on normal cells so that we have an enrichment in malignant cells and can minimize toxicities in normal cells that do not express this surface protein. This is a cartoon of such an antibody drug conjugate. It's actually more realistic than the previous cartoon because it shows you the dimensions. A monoclonal antibody is a pretty large molecule. It's described in kilodalton. It's at 140,000 kilodalton human IgG. And you can see chemotherapy payload is a very, very tiny molecule, but it could be a very potent molecule. And it's attached in these tiny little red spots, as you can see. So we're using a very large vehicle to transport these chemotherapy payloads into cells where the antibody binds to. Now, I mentioned initially that we have a lot of drugs that failed. So I think we can set up some rules that may determine the success of these new drugs. And I think the first is that it is a specific drug that is tumor selective. So this is a heat map showing you the expression of different genes, and they are very different. Red meaning up up-regulated and green meaning down-regulated. And you can see normal tissue is very distinct from tumor tissue. So we need to have a separation in that the protein is expressed only in cancer cells and not in normal cells to have a targeted delivery. The next is this antibody needs to be internalized. So it has to be sucked into the cell so that the chemotherapy payload can go in. And this is a cartoon just suggesting that I think of these like Trojan horses. You're actually transporting warriors into the fortress through an ADC, shuttling these warriors into the cell or into the fortress, and then being more effective and causing less damage in the surrounding. So this is an important requirement. The last thing is, or one of the important things is that this drug has to be activated in the cell. So not just transporting it in, but it has to detach from the antibody. And this is often happening by different pH levels, by enzymes that are located in the lysosomes, and therefore releasing that chemotherapy agent from the antibody. Then the other important determinant is that when that chemotherapy is set loose in the cell, it could actually penetrate out of the cell again into neighboring cells that may not have that same level of protein expressed that was initially targeted. And that is called a so-called bystander effect, so that the drug can actually attack cells in the larger area and not solely those that have the highest expression of the protein. There's a problem with bystander effect because it could increase the toxicity. Lastly, the drug that you're delivering into the cell has to be an effective drug. This is a laboratory model where you can see growth inhibition, and the bottom row shows less blue dots, meaning less viable cells, and is a more effective drug than the top, where you have outgrowth and overgrowth of cells. So clearly you want to have an active payload when you're using a drug that you're delivering to these cells, which determines the overall efficacy. And then there are patient-specific factors, and this is an immunohistochemistry picture showing you the different staining, the orange stain, of tumors on the surface of cells. So there are some tumors that have absolutely no dark staining, so that protein is very low in its expression level, and others are densely expressed, which will also determine how effective a drug is. Lastly, it will be important how patients are performing. Have they had many prior lines of therapy? That will also determine the success of an ADC. So you see, it depends on a lot of different variables, whether a drug that was developed in the laboratory really can be successfully utilized in clinic and help patients. This is a cartoon of those that are now approved. They're not many, 14 as I mentioned. The top line are those that are approved in hematologic malignancies, so blood cancers, and the bottom ones are those for solid tumors. Some of the names you may recognize, particularly for breast cancer. And we're proud to say that we have 3 of these that are now being used in the GYN malignancies, which is the trastuzumab deruxtecan targeting HER2. We have tisotumab vedotin targeting a protein called tissue factor in cervical cancer, and we have mirvetuximab targeting the folate receptor for ovarian cancer. Now, when we deal with ADCs, we are also learning a lot as clinicians and investigators, in that we're dealing with new toxicities on the one hand, but we are also dealing with known toxicities because we're delivering chemotherapy. So our hopes are that these drugs are better tolerated, but we still have to figure out some safety issues that are related to the payload, and they can be, as our experience has been in clinical trials, hematologic, they can be gastrointestinal, they can concern the peripheral nerve system and cause peripheral neuropathy. And we are also starting to deal with new toxicities, for example, ocular toxicities, which we don't see when we give the chemotherapy without the antibody. There are other side effects that are rare, like pulmonary toxicity, pneumonitis. So not only are we studying the efficacy, but we have to clearly focus on understanding the toxicity, but also being sure that drugs can be given safely with less toxicity. And this is an overview of those that are approved. Again, the cartoon from earlier, and just showing you the rates of ocular toxicity. And this varies a lot. So in some drugs, it's not seen, such as for the TROP2 targeting ADC saxagliptin govitecan, where we see little ocular toxicity, and others up to 70%, such as an ADC for multiple myeloma targeting the B-cell maturation antigen. We haven't really understood which drug and why they cause more or less ocular toxicity. So we are studying this, and one of the reasons for the toxicity that we see that leads to blurry vision is based on one of the three mechanisms. And you can basically, the theory is that one reason would be that the target is expressed on the cornea. Let's say we target a protein like HER2 expressed on some cancers, but it's been recently shown that HER2 is also expressed at low levels on the cornea. That would be target-induced toxicity. The other is that there are mechanisms that these ADCs are just being swallowed up and internalized into the cornea. And there's a well-described mechanism that's basically caused pinocytosis, a mechanism that's well known where molecules can be internalized through the membrane and be leading to these so-called inclusion cysts or keratopathy. And then there is, lastly, basically the bystander effect that chemotherapy, which is dissociated from the antibody, just loosely returns into the outside of the cell, the extracellular matrix, and enters basically normal tissues. So which of these are the predominant mechanism? It's not quite understood yet, but we're learning more and more so that we can also develop strategies to mitigate these new toxicities with ADCs. And one of the main strategies to reduce this new toxicity of ocular side effects is to hold the drug and let the cornea heal. And for me, it was fascinating to understand that the cornea is tissue that is actually a tissue that does not contain any blood vessels, but recycles incredibly quickly. So the human eye replaces the cornea, which is the outer layer protecting the lens, within about 10 days completely. That means if any damage is set by an ADC, within about a week, that damaged area would be replaced. So holding the drug, giving it time to heal, usually leads to full recovery. And it's been my experience that the ocular toxicities that we see are completely reversible when the drug is held or when the drug dose is reduced. And I hope this is encouraging for those that are on the call that have been experiencing some of these side effects. This is not a permanent eye damage, but it is a toxicity that can be extremely bothering, but it is reversible. And one of the drugs that is characterized with ocular side effects in about half of the patients is the folate receptor targeting ADC that was recently approved for platinum-resistant ovarian cancer. This is the first ADC to be approved in a GYN malignancy, and it was explored in the so-called MIRASOL. We have all these funny acronyms for studies so that we can memorize them when we discuss them at meetings. But in the MIRASOL study, patients were treated that had platinum-resistant ovarian cancer, either with the new folate receptor targeting antibody drug conjugate, the marketing name is Elahere, or mirvetuximab soravtansine, versus our best available standard of care, which was either weekly paclitaxel or liposomal doxorubicin or topotecan. And the study showed that giving targeted chemotherapy such as an ADC targeting the folate receptor was clearly more effective, and that 42% of the patients had either a partial or a complete response, as opposed to only 16% of patients with platinum resistant. That means patient that had failed 3 prior lines of chemotherapy where the disease had recurred within 6 months. So this was also leading to an improved progression-free survival. And the way these curves are read is that we see that there's a shift of the blue curve compared to the black curve to the right, meaning the median progression-free survival was extended. This was statistically significant. So it wasn't just equal to chemotherapy, it was superior in extending progression-free survival and also extending overall survival. So all three endpoints of the study were met. And most importantly, it was also better tolerated with lower toxicity and improved patient-reported outcomes. So I think a major milestone of introducing a new targeted antibody drug conjugate, a drug that was not available and is now a new addition to the armamentarium for the treatment of patients with platinum-resistant ovarian cancer. Now, the second ADC was recently approved for GYN malignancies that was already approved for breast cancer, which targets the human epidermal growth factor receptor 2, HER2. This is a target that's well familiar to patients diagnosed with breast cancer because it's seen in about 20% of patients. In breast cancer, its alteration is usually caused by an amplification, meaning increased copy number of the gene encoding the HER2 protein that's expressed on the surface. In GYN malignancies, we are actually measuring HER2 just by looking at the protein on the surface and not required to do gene amplification. And this has been expressed in GYN malignancies for quite a while, and I've been pursuing this protein for many years. But this is exciting to see that we now have an antibody drug conjugate that targets HER2 and can deliver a chemotherapy payload with greater precision and lead to very meaningful responses and acceptable toxicity. And this is data from what we call a pan-cancer study. So the company conducted not a study specific for a certain disease entity, but really studied the drug across a wide range of tumors, including endometrial, cervical, ovarian, bladder, and biliary and pancreatic cancer, and looked for a signal of activity. And when you look at this plot, I'm sorry, it's a little busy, but on the bottom line, you can see the response rates that mean the percent of patients that benefited in that the tumor shrank significantly or either disappeared, so the response rate, and ranging up to 100 for either endometrial, cervical, or ovarian cancer. Now let's focus on, for example, endometrial cancer. These are patients that were then split by the level of HER2 expression, either high, intermediate, or split by the number of prior lines of therapy. And you can see in patients that had high expression of HER2, there was a near 80% response rate. Now, keep in mind, these numbers of patients are relatively small, but these data were so strong that the FDA granted approval for this drug across these three indications. So this has now been a new drug that's available should the tumor show either high or intermediate expression of the HER2 protein. Clearly, the activity is higher, the higher the protein is expressed. And this holds true for patients diagnosed with cervical cancer and ovarian cancer. So this is an exciting new development. It also shows you that when we talk about the development of ADCs, it's not that relevant anymore what diagnosis you have. It's really relevant which protein is expressed on the surface of the cell. Now, this opens a lot of new questions, and that I think is relevant for some in the audience is if affected by any of these cancers, does the tumor have HER2 expression? This is a study that was conducted that looks at a problem we've been familiar with, and that is regarding the reproducibility of HER2 testing compared between local labs and central labs. So central labs would be labs that are specifically trained. They're usually high volume labs. These could be commercial labs or it could be academic labs that do a high volume of these tests that are often very standardized. Or local could be a smaller hospital that doesn't do that many of these tests. And we've known that there is often difficulty in interpreting whether it's high expression or intermediate expression. And the reproducibility of this, you can see between local and central lab testing isn't that perfect. That means 62%. That means still about 4 out of 10 patients, the central lab had a different test result than the local lab. And that was even more when you looked at the intermediate expression of HER2. So this really is important, that I think when you have a test result, that you may ask for it to be retested at a central lab to see if the result that is measured in a local lab is accurate. Then another interesting study came up, just recently published in scientific reports, that showed, well, which biopsy do you take to test for HER2? Do you take the original biopsy from the initial surgery, or do you undergo a new biopsy because you've had 3 or maybe even more lines of therapy in between since your diagnosis? And it looks at the changes of the test result over time. And it showed that HER2 was actually upregulated in a small study, but in 11 patients, meaning that actually in 60% of the patients that were tested, when looking at more recent tissue that was exposed to more treatments, higher levels of HER2 were found. And this is important because if you want to know whether this ADC works for a patient, it makes a difference whether you do a more recent biopsy. So this data suggests that if the initial biopsy is negative, maybe obtaining a fresh biopsy will give you more accurate information about the current status of HER2 expression. There's also another explanation, and that could be that old tissue may lead, or storage of tissue over years may lead to protein degradation, so that the block that lies in the pathology lab of the hospital where you were operated on, that this protein may have just degraded over time. This is a known phenomenon, so that again underscores the importance when we're talking about looking at a target, maybe use a more recent tissue. And that means you could ask your physician that maybe there is a role for a recent biopsy or a new biopsy, particularly because it's about making a decision whether a drug works or does not work in a specific case. Now, the space is getting crowded. We have a lot of new ADCs in development that target the folate receptor. Again, the top in this table is mirvetuximab. This is a drug that was recently approved. You can see there are others in development. One is called luveltamab. They have slightly different chemotherapy payloads they deliver. There's another one called MORAb-202, and there's a more recent one called RENA-S. As you can see, they have different drugs they are delivering, and the exciting opportunity this is providing us, that maybe patients that once they fail responding to the initial ADC, the mirvetuximab, approved for folate receptor positive recurrent platinum-resistant ovarian cancer, may respond to one of the others because the drug you're delivering is a different one. This is the drug and the data for one of the ones I mentioned in the previous table, the luveltamab tazevibulin, and it really highlights that the names these drugs are giving are becoming more and more complicated to pronounce. But that's why we use little acronyms like Luvelta. This is a folate receptor targeting ADC, which showed very promising data in earlier clinical studies. You can see this on the waterfall plot. Each bar represents a patient, and the further bar down the bar drops, the greater the regression or the decrease in size of the tumor is. And you can see overall response rates at different doses are very promising. So this is moving forward. This is another early clinical study summarizing the data from another folate receptor targeting ADC called RENA-S or rinatabart sesutican. And you can see this is delivering a different payload. This is not a microtubulin inhibitor. This is a drug called a topoisomerase inhibitor, so it works very differently. And our hopes are that if we deliver this drug into cancer cells that have stopped to respond to a microtubulin inhibitor, we could, again, have a successful shrinkage or response to this second generation folate receptor targeting ADC. The interesting thing also is that This is a new ADC that seems to work at lower levels of folate receptor expression. And I forgot to mention that that first ADC that targets the folate receptor is only approved for patients that have very high levels of folate receptor. That is determined as a cutoff of 75% of 2+ or 3+ intensity. Any patients below that, the data so far suggests that the drug is not superior to standard of care chemotherapy and was therefore not approved. This, however, in contrast, Rina-S is an ADC that seems to be working at lower levels of folate receptor, as you can see on this plot here. Folate receptor below 75, you see basically the percent of response being significant, but also in those above 75, very comparable. So exciting data. This is moving now forward, both of these into large randomized phase 3 studies. And phase 3 studies are required for the FDA to have data to see whether this drug is superior to best standard of care. And it could be that these two drugs will also be available for treating folate receptor positive patients with recurrent ovarian cancer. And this is the randomized study for the Rina-S molecule. These are open within the United States. So one of the institutions close to you may be having one or the other of these trials open for your treatment. Let me move on to another target. So we discussed the folate receptor, we discussed HER2. A third target that's now being pursued is called TROP2. This is a surface protein that is actually a calcium channel transducer. It promotes tumor proliferation. It's very important in multiple cancers and is very highly expressed, particularly in ovarian and endometrial and cervical cancers. So it's a novel protein, selectively expressed on cancer cells and only expressed in lower levels in normal cells. And again, there's a lot of competition. There are now 3, in fact 4 TROP2 targeting drugs available, and this just shows you the data for the early experience in endometrial cancer. One of it is called saxetumab govitecan, a drug that's approved for triple-negative breast cancer. Another one, saxetumab tirumotecan, which is developed by Merck, and another one, dapotamab deruxtecan, developed by Daiichi. Different payloads, different drugs, in the sense all show promising clinical activity in patients with extensive prior treatment. We measure this as the objective response rate. So we have a number of interesting drugs moving forward in endometrial cancer, also in cervical cancer, and in ovarian cancer, where the protein TROP2 will be targeted. Now, I just wanted to show you the 2 large studies that are moving forward in endometrial cancer with the TROP2 targeting ADCs. You can see these are studies that are conducted in Europe through the ENGOC network and the GOG network. This is the, you can see the saxetumab trimotecan, the MK2870, a large randomized study of this drug versus standard of care chemotherapy in recurrent endometrial cancer, and another large phase 3 study also exploring the saxetumab govitecan versus the same standard single-agent doxorubicin or paclitaxel in endometrial cancer, in our hopes that these studies will lead to the same results that I showed you for the mirvetuximab, with an improved response rate, improved progression-free survival. It gets busier because there's another target that is now being pursued that's called cadherin-6, that is highly expressed in some cancers and lower in normal tissue. Very promising waterfall plot, very durable responses. And this is also going into a larger phase 3 study where this new cadherin-6 targeting ADC will be compared to standard of care chemotherapy initially in a phase 2, leading into a phase 3 study. So a lot of trials in development, a lot of new targets that we're pursuing with novel payloads. And lastly, I wanted to review a little bit on the data of a drug that is developed at UCLA. And we developed this specifically because we wanted to improve further upon ADCs that are currently in development. And we spent a great deal on an effort on identifying maybe even better targets to pursue than the folate receptor, than the TROP2 or HER2, in that we did a systematic analysis of surface proteins that is publicly available data where we basically look at which proteins are expressed on the cell surface. Then we boil it down to which are expressed in cancer cells. And then we select those that are low or not expressed on normal tissue. Then we select those where we have models in our laboratory where we can test new agents. And then we basically pick 20 based on non-overlapping interests with other developments going on. And one of these proteins that is a top candidate is called Claudin-6. This is another target. And I wanted to show you why we're excited about this protein is because in this little blot down here, you can see many cancer types. And every little dot represents the expression of an individual patient. And you can see these bubble blots are very high in testicular, but also in ovarian and uterine cancer. So this is a target that's very highly expressed in ovarian cancer as opposed to other cancers like bladder or liver seen on the other side. Its high expression is also associated with adverse outcome. But what's more interesting, this is a protein that is not expressed in adult normal tissue. It is actually only expressed in embryogenesis during early intrauterine development of an embryo, and then is lost, but is re-expressed when a malignancy occurs. And this is an example of the expression of this protein across normal, healthy tissues. The red bar is the detection limit, and you can see it's absent. It is not expressed on any normal tissue. How does this compare to the other targets I just showed you? Well, the red bar is the reference, and you can see this is Claudin-6, not expressed on normal tissue. However, the other targets we just talked about, there are some tissues that have relevant expression. And this may be a possibility for some of the on-target toxicities we see with these ADCs that target TROP2 or folate receptor. The red is the expression of the protein in lung tissue, and you can see some of the drugs that do cause lung toxicity in a few patients, like pneumonitis, do have higher expression of folate receptor in lung tissue or cadherin-6 or TROP2, which is not the case for Claudin-6. So our hopes are that this may be a target that would even further reduce side effects seen when giving the drug. And so UCLA created a monoclonal antibody through a standard technology. I won't go into the details, but you inoculate mice with a purified protein, you extract the spleen cells, you fuse them, immortalize them with myeloma cells, and then you basically select an antibody clone that inhibits the growth of models of this cancer, and you see the blue line suppresses it the most. So this clone was further selected. It was then what we call humanized. It is then made nearly identical to a human antibody. It's not a mouse antibody anymore, except the variable domains, and then can be safely given chronically to human beings. Then we went a step further and didn't just create a monoclonal antibody targeting Claudin-6. We created an antibody drug conjugate with a cleavable linker and a payload that has been studied in other diseases. And this has now been shown to be highly effective in animal models, as you see on the gray line. We then went on to do a phase 1 clinical study, which is intended to understand whether the drug is safe, but also intended to pick the most active dose to take forward. And in the meantime, you can see we have completed the dose finding study. We have now opened what we call dose expansion cohorts. So we treat specific patients, such as platinum-resistant ovarian cancer, any other tumor type that expresses high levels of Claudin-6, such as non-small cell lung cancer or endometrial cancer, or testicular cancer. But also we're obliged to treat patients that have low levels of Claudin-6 expression to be sure that the presence of the marker predicts improved response. This is a busy slide, and I'm not going to spend much time, but overall 80 patients treated so far. These are patients that go on this phase 1 clinical study, often having failed up to many prior lines, some patients up to 7 or even up to 9 prior lines. So we call this extensively pretreated. The majority of patients were ovarian cancer. And you can see this is a very busy slide, but the bottom line is that we spend great detail in studying the toxicities from very low doses to the maximum tolerated dose. We have identified a dose that can be safely given without causing what we call dose-limiting toxicities, and with a very low safety profile, meaning no ocular toxicity, no lung toxicity. Over time, some patients developed slight neuropathy and a drop in the white blood cells, which we can treat with growth factors. So we've passed the first hurdles, and that it's a very safe molecule with very promising activity, in that platinum-resistant ovarian cancer showed a high promising response rate between 42 and 50%. This is early data. These are small data sets, but this is now moving into a clinical study that is called a phase 2 study, a global study, and that's the reason why I'm in Korea, because the Korean sites will be participating in further studying this novel ADC targeting a new protein. So in summary, I want to conclude. It's an exciting area to do drug development, particularly for GYN malignancies. We have the first newly approved ADC, mirvetuximab, in ovarian cancer. We have new targets that are now available, such as folate receptor and HER2. It is required to test for the expression of these proteins in order to get access to mirvetuximab or the HER2 targeting ADC called TDXD or Enhertu. There are new questions that arise about the reliability of testing, and it is important that you inquire with your physicians or caretakers and really test, is this central or local lab testing? Was this done on the archival tissue? Should a new biopsy be done? Because it's very important to get the best quality of test result and not be excluded from access to these drugs just because a poor test was performed. We're dealing with new side effects, such as the ocular or pulmonary toxicities, and learning more how to mitigate and reduce these. And I think one of the key findings, and I hope I related that, is that the expression of the target antigen in normal tissues will determine toxicities, and that we're striving to really find new drugs that have absolutely no expression of the target proteins in normal tissue to minimize the potential toxicities. And this is an exciting area moving forward, and I look forward to answering any questions that you have. Apologize if I went a little bit over, but thank you very much for your attention. It's a pleasure and honor to be participating in this symposium. Li Mei Chen, I'll give it back to you.
Thank you so much, Dr. Konecny. That was marvelous. I think that it gave us a really great overview of the significance and also the way that drugs are developed. I applaud the work that you're doing at UCLA. Start my video. No. Oh, here I am. Good morning, everybody. I think the work that you're doing at UCLA is inspirational to all, and I know that many of our patients here are interested in finding out more about both that study as well as more of the applicability of antibody drug conjugates. I'm going to start with the Q&A because there is a question there about use of ADCs for high-grade serous endometrial cancer in the recurrent setting. I think that there is applicability, and I'll let you address that.
Absolutely. I think we're just not there yet because we don't have, other than the HER2 targeting ADC, an approved drug such as the folate receptor targeting drug, which is only approved yet for platinum-resistant ovarian cancer that has high expression of the folate receptor. But the receptor is expressed in high-grade serous uterine cancer very frequently. The drug will work in that space. The studies are ongoing. And I think if you're interested in this approach, you have to look for a clinical trial in your neighborhood that would allow you to participate in one of the newer drugs that I just briefly reviewed. Yes, this is the future for endometrial cancer. There are, I think, three or four that have great promise to move into the clinic very soon. But as of today, it's really only the HER2 targeting ADC and HER2, which has FDA approval if you have high expression of the HER2 protein.
Thank you. Yes, I think the age of precision medicine is here. There's a question from the chat that is from a biology student who is from Peru at UPC. And he has a question about they have a question about aptamers. They're a member of the aptamer group and wanted to know what you thought about using aptamers in targeted drug delivery.
Also, the future will tell. Aptamers are less complete proteins that compared to a large monoclonal antibody. They have certain pharmacodynamic advantages, but it's all going to come down to the clinical trials to prove whether they are as effective as ADCs. But it is, I think, a new platform for delivering payloads in a targeted way. And I look forward to more science coming out of your lab, and hopefully that these will move into clinical trials very soon.
That's excellent. So if there is interest in your trial, what do you recommend to our patients? We're going to have a session later on about participation in clinical trials, but as I said, I know that there's great interest in the Claudin-6 and the Trop-123 that you were describing earlier.
Mm-hmm. Well, I think any patient on the call has probably had experience with screening for trials, and trials are often very specific in asking for criteria like the number of prior lines, absence of certain toxicities, the so-called inclusion criteria, and also the availability of what we call slots. These are often studies that are done throughout the entire nation. And so it's not like you have necessarily a guarantee that you will get access to one of these drugs. So I want to just jump ahead and don't want to create false expectations and hopes that the drugs you've heard today in the talk will be readily available in a clinical trial. It's sometimes cumbersome to get access to a trial. It requires often travel. In many cases, there are safety reasons or just logistical reasons that the drug is not available. So I think the best approach is to have an open mind, to be interested in trials, to follow up, get second opinions, go to academic centers. There are numerous in Southern California, and just ask about what are the clinical trials that are available for my situation, rather than finding something that that may not be successfully applied because of various reasons. I just don't want to create sort of the expectation that you heard a drug now, oh, that's something that I want to get access to. There are a lot of hurdles getting it, unfortunately.
And I think you presented some outstanding science. I would outline the fact that it takes years to get from the idea, your development of a target, it takes time to develop the antibody. And so I appreciate the fact that these are game changers in our practice, but in terms of the amount of time it takes to get from the concept to availability broadly is still quite a long period of time. The good news is that there are more treatments. We're doing better with them. So we hope that in the time that it takes to get to our patients, we have that time to have alternative treatments and be able to get people along.
Yeah, I think the ADCs are a new era of clinical trials also, because many patients shy away from clinical trials because they say, oh, it's an experimental drug. It's not validated. There's less experience on this new agent. It is true in some respect, but ADCs are is a concept that has been successfully implemented in 14, FDA indications already. And sometimes it's just a different target that's being pursued or a different payload. So we're not reinventing the drug, but the FDA still requires these drugs to go through a rigorous process of clinical testing. So it is often that we can expect patients that go on what we call a phase 1 study. What used to be a study that purely was aimed to look at the safety and not even asking whether there was activity. It's safe to assume that we will expect activity in a phase 1 study. So it just changes, I think, the acceptance of clinical trials and phase 1 studies because, with an ADC, you're extremely likely to see activity if the target is picked right and the payload is right, but it still has to go through this formal drug testing process, which often takes very long, as you pointed out. Yeah.
Are there enough different payloads? Because it seems like if you have the antibody, that's your target. If your payloads are similar, and we talk about this in terms of the topoisomerase inhibitors, right? If someone's been treated with topotecan before, is that a good ADC for them, or is there, some other chemotherapy that we should be choosing before using that ADC?
Yeah, I think your question is extremely important and relevant, and we don't know that yet because the question of how do you sequence them will be very important. Is the same phenomenon that retreating with a similar payload will be less effective as we see with standard of care? Or could you overcome this by attaching it to a different target that may be more higher expressed in a tumor? Those are all unanswered questions, and they will be, I think, the objective of ongoing studies moving forward. And we'll be learning, every year or every month, and at every of the upcoming meetings, we see new pieces of information on how to schedule and prioritize these. It's just a fascinating area, rapidly evolving, and we don't have all answers yet.
Well, thank you for introducing us to your science and get kicking off our